Ophtho. Here we go. Okay, my name is Jan Schoenberger, as Rick said. I come from Los Angeles, from LA County, USC. I was a program director there for almost 10 years, just stepped down not too long ago. And I am not an ophthalmologist, but I am going to talk about ophthalmology. And in terms of the ABEM exam, I mean, obviously ophthalmology is a huge area of expertise. And I will confess, speaking on behalf of myself only, that it's probably one of the areas where I feel a little insecure about my knowledge base compared to my specialty consultant, because they know so much. But really, in terms of what ABEM wants from you for the exam, is they want to know a few things. They want to know, do you know what to do with the really common things that we see, day in and day out? Do you know which things, when you see them, are real emergencies that are vision-threatening that you have to call an ophthalmologist for immediately? And then sort of the in-between sort of urgent things that we see. But it's really focused on those, the spectrum of disease. So some of these things we don't see very often, so I hope this is a useful review for you. And we are going to start from the outside in. So we're going to first start talking about conditions that affect the external eye. These are things that we really see day in and day out. Then we'll talk about the infections of the soft tissues of the eye. Then we'll get into the red eye and what the differential is there and how to tell the difference in the vignettes between those things. We'll talk about patients who present with vision loss and what the differential is there. Then we'll talk about trauma to the eye, and we'll finish off with the most painful part of the talk, which is the neuro-ophthalmology, the innervation of the eye, what controls the pupil and the anatomy of the lids, and particularly talking about ptosis and how to tell the difference between different syndromes. So this is sort of your standard eyeball anatomy slide that you can always refer to if you're trying to remember, wait a minute, where's the cornea exactly, and all the different structures there for your reference mostly. So let's start with the outside of the eye and talk first about blepharitis. Blepharitis is the inflammation of the eyelid margin. You see this often in people who have things like seborrheic dermatitis. They get kind of a chronic staph infection around the hair follicle base. Often it's kind of burning, it's red, it's itchy, and this is treated very conservatively. Maybe some baby shampoo, kind of clean it up a little bit. If it's really angry, maybe add a little topical antibiotics. This is someone who has blepharitis. You see how it's sort of spread across the lid margin, red, sort of raised, but the eyes underneath look just fine. That's blepharitis. Now, dacrocystitis is another external condition. This is when you block up one of your lacrimal ducts, usually the inframedial duct below the inner canthus there. Sometimes people have excessive tearing. Some people, the tearing's not draining, the tears are not draining. Sometimes a little bit of pus can come out of that canthus as well, and you can get an associated cellulitis if it's really obstructed. These we typically start with some, warm compresses. If it looks particularly angry, maybe some topical antibiotics. If it's really got some cellulitis there, we might go systemic, and some decongestants can sometimes be helpful as well. Here you see that dacrocystitis, that swelling on the inframedial part of the eye there. There you go. Ooh, look at this fancy pointer. I love it. Okay, there you go. There's my swelling there. Now, a hordeolum, a sty of the eye, the fancy name for sty is hordeolum, is really an abscess usually staph, at the lid margin. And it's painful, and it's red, and it's acute. And it can be external, it can also be internal. And again, we see these all the time, warm compresses, maybe some topical antibiotics if we think that's necessary. But again, the globe underneath looks relatively well. This happens in kids, adults, super, super common. One of the things to differentiate is hordeolum versus chalazion. These two things are often confused. Now remember that chalazion is actually a chronic internal sterile granulomatous reaction of the meibomian gland. And so this is usually not tender and not inflamed, although sometimes they can kind of flare up acutely. And the key to it is kind of where it is. It's usually in the upper mid portion, and it's usually just a little away from the lid margin itself. And that's different than a hordeolum, actually. Now, often when we see these, we still try what we know how to do. We try some warm compresses. We might recommend some topical antibiotics, but often these need to be referred to ophtho for an IND or kind of an excision if they're not responsive to these things, which they often aren't. So if the story is it's been there a long time, then often these will end up needing a referral, certainly not emergently. Remember that you can get squamous cell cancer of the skin of the eyelid, and sometimes it can look a little similar. So if it looks irregular, that definitely would be need to refer for a biopsy. Here's a picture of a chalazion. You see how, yes, there's a bump externally, but when you really kind of pull the lid down, it's actually internal, and that's where the chalazion is. All right, let's move on to the soft tissues of the eye and talk about periorbital or preseptal and orbital cellulitis. This is sort of a favorite topic of question writers because these two conditions are actually quite different, and they like to ask questions differentiating these two things. So this happens often, like any other cellulitis, can happen from sort of micro or macro breaks in the skin, or even a sinusitis, a spread from something that's pretty contiguous. It's the usual skin organisms. It can be staph, it can be strep. We are seeing a little more MRSA in this category as well. And the difference between periorbital and orbital cellulitis is really based on the anatomy, because we have this orbital septum, and that orbital septum creates a closed space in the back of the eye to really protect all of those vital structures that we have there. So you see here in this, you see where it says orbital septum, and this red line that's kind of dividing here. And this red line creates really a compartment in the back of the eye. And this is why a lot of these inner eye things are such emergencies, because we have this closed space. And so things that create inflammation or swelling or blood that's in that space can really lead to ischemia of the retina, because it's pushing on the artery and threatening your vision. So periorbital is in front of that septum, which is why we often call it preseptal. And then we have orbital cellulitis, which is in the back, and they really look quite different. So periorbital cellulitis, which we see externally, is a little bit of, it's cellulitis around the eye, but they often don't have a ton of pain. The globe itself looks normal, and as they move their eyeball around, it doesn't hurt that much, and that's a big differentiator from orbital cellulitis. They may have some fever, it can be erythematous, they can have some edema, but again, that globe should look normal underneath. We treat this with systemic antibiotics. You can go Bactrim, you can go Clinda, you can go Augmentin. There's a few choices there for you, and usually these can be treated as an outpatient, because generally these patients look well. Every once in a while, you might have a patient who's immunocompromised, you have another reason to be a little more concerned, and you might do a little more, but in generally, preseptal cellulitis or periorbital cellulitis is typically treated as an outpatient. Here's a kiddo, it's got a little swelling around the eye there, she looks pretty happy, she's not toxic, she's not going to tell you she has a ton of pain. Orbital cellulitis, especially at ABEM General, is a patient who looks really sick. This is a toxic appearing patient who's got some pain, especially as they move their globe around because of where that infection is located. Sinusitis is the most common origin of this infection. The lids look pretty dark, and often they have some proptosis described because of that swelling and where it's coming from. And decreased mobility may be also in the descriptor as well. Your bugs are staph and strep. You may have H. flu on that list as well. So again, as I mentioned, because of this closed compartment created by the orbital septum, orbital cellulitis really does have some serious complications that are at risk here. As you increase that intraocular pressure, you can decrease the blood flow to the retina, which can lead to decreased visual acuity. So these patients get the full meal deal. They get a CT scan. They get IV antibiotics. They get admitted. Ophtho is called. They have a lot of complications that can happen. They can have meningitis. That's the most common one. They can also get a cavernous sinus thrombosis. Think about where that infection is. And they can get orbital and periosteal abscesses as well. So the workup here is labs and CT scan and admission. Very different from periorbital cellulitis. So again, something that test writers like to differentiate those two things. Here's orbital cellulitis, not subtle. The globe does not look normal. The eye is very red. This person would be described as toxic, in discomfort, can't really move the eye around, very different. That gets the full meal deal. Now let's talk about the patient who presents with a chief complaint of the red eye and what our differential diagnosis is there and how we're going to tell the difference between these different entities. So we see conjunctivitis a lot, very familiar with that. We see foreign bodies of the eye a lot, and we're going to talk about uveitis and iritis, narrow angle closure glaucoma, and keratitis as well, which is really cornea-itis. That's how I think of it. It's really an itis of the cornea is keratitis. So first, conjunctivitis, we're very familiar with this. We know that there's viral and we know there's bacterial. Viral is certainly more common. Again, in our real lives, in clinical practice, it's sometimes difficult to tell the difference between viral and bacterial conjunctivitis. At ABEM General, all of the textbook rules are kind of followed. So if they want you to really get to an answer of viral conjunctivitis, they're going to tell you about a watery discharge, that kind of thing. Somebody had a URI recently. They're going to throw in all those classic features of a viral conjunctivitis. So pink eye or viral conjunctivitis is usually from an adenovirus, although there are other viruses that can do it as well. Typically it's thin, watery discharge, maybe starts in one eye, then goes opposed to the other. There's some URI in the story. They may have some pre-auricular lymph nodes that you can palpate, but their visual acuity is normal, intraocular pressure is normal, the pupils look normal, and we do a little sort of just symptomatic treatment. Warm compresses, wash your hands if you were really sure it was viral conjunctivitis. So a supportive treatment, and that's the most common etiology of conjunctivitis. Now, there is a subtype of viral conjunctivitis that's particularly nasty, which is called epidemic keratoconjunctivitis. And really, this is more of a keratitis than a conjunctivitis. This is a pretty angry red eye. They may even have chemosis and tearing. And on the slit lamp exam, they may even have a little bit of uptake fluorescein-wise. This lasts a little bit longer and really should be referred to ophthalmology because it's really not a true sort of basic conjunctivitis, because they might even give it some steroids to sort of calm things down. Here's a picture of someone with EKC, just a pretty angry red eye. Now, bacterial conjunctivitis classically is more like purulent discharge, not that thin, watery discharge. They typically don't have adenopathy. And the thing to know about bacterial conjunctivitis, besides your regular staph and strep, is don't forget we've got gonococcus on the list. We've got gonococcal conjunctivitis. And any vignette or a story where they ever say the words contact lens, you have to think about Pseudomonas. Contact lens, Pseudomonas. Contact lens, Pseudomonas. You want to make sure you're covering Pseudomonas in that patient. When they really describe someone who has copious, purulent discharge, it is coming out nonstop. Think about gonococcus as an etiology there. And if it's gonococcal conjunctivitis, that takes it to a whole extra level because that patient needs IV antibiotics, that needs a culture, a gram stain, and they can even progress to perforation in those cases. But for regular bacterial conjunctivitis, we treat it with topical or antibiotic drops. We don't patch these anymore. That's our treatment if we knew it was bacterial. They could bring up neonatal conjunctivitis. I think it's probably unlikely, but remember that this is something to know a little bit about. There are some different etiologies here depending on when you're talking about from time from birth. If you're talking about the first day or two in neonate with conjunctivitis, you might think about a chemical conjunctivitis. And then we move on to a few more days, and now we're talking about organisms that the baby acquired in the birth canal. We're talking about GC, talking about herpes as a potential etiology, and then there's chlamydia that starts to come onto the scene. And if they're going into a chlamydia conjunctivitis scenario, they'd probably also tell you that this patient has otitis and maybe a pneumonia, a staccato type cough, that chlamydia triad that they might be getting to there. When we move on to 5 weeks and going on, then we're talking about regular old conjunctivitis. We've sort of left the neonatal etiologies behind. Gonococcal conjunctivitis, again, will be described as just excessively purulent, that there's just copious purulent discharge. Think about GC. Now let's move a little further into the eye. Let's talk about uveitis and iritis. And remember that as we move into the back of the eye here, we're talking about the uveal tract, and there's some things here to remember. So the iris is the colored part of the eye, of course. The ciliary body is the muscle that kind of attaches to the lens of the eye. And then we have the choroid, and the choroid is sort of the nutrient vessels that go behind the eye there, and they nourish that eye. So as we get infections and inflammation along this track, we're talking about uveitis. So this is as these structures get inflamed, and there's many causes. You can obviously have traumatic iritis, but you can also have infectious causes here, and don't forget about the rheumatologic causes of uveitis, etc. Typically, patients present with red eye, but in addition to that red eye, they're talking about decreased visual acuity. Now we're talking about someone who does not have perfect visual acuity, contrasting with someone with conjunctivitis who usually does. They're talking about more of a deep ache, describing more of a deep ache in the eye. Photophobia starts to enter the vignette here. And then we've got varying degrees of redness. They don't have discharge associated with it, again, differentiating it from conjunctivitis. On a slit lamp exam, you'll see that cells and flare, those white blood cells from the inflammation going on, and they can have meiosis or they may have mydriasis, depending on the etiology of the iritis. So, for example, if they got hit in the eye with a ball or something and they tore their muscle, then they might have mydriasis if the sphincter is torn. But often, clinically, iritis, if it's not traumatic, may have actually myotic pupil, a small pupil. So it can either have a small pupil or a big pupil and still be iritis, depending on the etiology. How do we treat iritis? These get a referral to ophthalmology. It's not emergent, but it's urgent. They get cycloplegics if they're having a lot of pain associated with this. Steroids may be on the list as well, if recommended, and analgesics to treat that inflammation. So here you see a little picture of a red eye that might be from iritis. You note that right around the outside of the iris, you see that outer ring of redness. You don't have that limbic sparing when you're talking about iritis. Sometimes you might see a hypopyon, the layering of white blood cells in the anterior chamber. That may also be associated with the iritis, depending on the etiology. That is that classic layering, and we have a lot of pictures in the ophthalmology talk because it's a common area for the visual stimuli to be showing you a picture like this and asking you questions. So hypopyon is what we're seeing there. Sometimes a corneal ulcer could be associated with this as well, and you see that sort of defect in the middle of the cornea associated with, again, a hypopyon or white cells in the anterior chamber. Now, endophthalmitis is not subtle. This is really where you have a purulent eye that is sort of at the end stage of an infection. It's a really, really big deal. And as the intraocular cavities just become overwhelmed with infection, then we're talking about endophthalmitis. Most of these cases are patients who have had some kind of surgical procedure that now is, all infected. This is post-cataract surgery is one of the scenarios for this. It can be post-traumatic, the person who got stuck in the eye with a stick or something particularly dirty. It can every once in a while be an endogenous source, some kind of a septic emboli, something like that, that can basically take over the eye. Now, how bad it is, depending on how bad the involvement is, but we're talking about a painful, injected, usually at least a hypopyon, if not more, very edematous, decreased visual acuity, end spectrum of infected eye. And it will really depend on where it came from. But this is going to be IV antibiotics. We're talking Vanco, we're talking Gent, we're talking big guns, because this is really ocular threatening. And if it's fungal, if you think that that might be the etiology, then we'd obviously go with amphotericin. So this is really an ophthalmologic emergency because of the threatened ocular cavity in general. Again, not subtle. You would not think this was keratitis or really anything else. You see the chemosis there around the edges of the eye, around the cornea there, and you just see that this eye is just destroyed with just purulent material. There's hardly recognizable structures. That's endophthalmitis. Okay, keratitis. Keratitis, as I said, is corneaitis. It's inflammation of that cornea. So we're going a little deeper than the conjunctiva. And this can be, again, from a variety of causes. It can be bacterial, can be viral, could be fungal. Could be something like Sjogren's, something more autoimmune. It could be also from exposure, like UV light exposure, or even drug toxicity, chemical keratitis. And then you also will get that perilimbic flush, that circumferential redness of the sclera at the edge of the cornea. Now, if we're talking about superficial keratitis, we're talking about just on the surface there. And often there's some etiologies here you'd think about. UV light might be one of them. This could be from someone who's a welder, could be the snow blindness thing, could be sun lamps. And often they have an exposure of UV light, and the onset of their keratitis is a little bit delayed from when the actual exposure happens. Someone who's got dry eye could lead to this. Could be some kind of topical eye drops that are being used causing a toxicity. And again, if contact lenses in the vignette, think about Pseudomonas. And if you were to fluorescein that eye, you might see a little bit of stippling there, a little bit of defect under your slit lamp exam. And you have to think about where it's coming from and treat that underlying cause. Again, if there's contact lenses, go for the Pseudomonas coverage. So here you see that kind of stippling. This is UV keratitis, these superficial defects there on the outer layer of the cornea. Again, you see that perilimbic flush, all those vessels kind of coming in around the edges of the cornea, indicating that it's a corneal type of involvement. Now, bacterial can be on the list here, often associated with more like ulcers with the keratitis, and you'll see these white spots, those corneal ulcers. And when you see that, think about bacterial keratitis. And really, there's lots of etiologies here. Again, most of the lists that we talked about with conjunctivitis, we're just talking about it now in sort of a deeper layer. This is usually quite painful. Often there might be an associated iritis along with the keratitis, and they may have a hypopyon associated with it as well. Depending on how deep and how involved it is going to possibly mandate IV antibiotics versus topical. All depends on what kind of level of deepness we're talking about with this particular patient. You can have patients who have immunosuppression or have some kind of other etiology to give you a fungal source of the keratitis. Patients who are on long-term steroids, that's where we start thinking about potentially a fungal type of keratitis. And then we have to talk about the viral etiologies. We've got herpes simplex and we've got varicella. Both of these things can cause a keratitis. They're a little bit different in subtle ways. So let's talk first about herpes simplex keratitis. So you can see this in neonates acquired through the birth canal. You can also see it from patients who basically can inoculate themselves with primary, herpes simplex virus. And the difference, how are you going to tell this from varicella type keratitis? Well, you'll often give it a history of some herpetic vesicles on the lid or a picture of them, which I'll show you. And if you stain that cornea with your fluorescein, you see that typical dendritic pattern, almost like a tree-like pattern when you're talking about viral keratitis. They classically are described as having a decreased corneal sensation with herpes keratitis, and we treat these with antivirals for sure, cycloplegics if they're having a lot of pain. And when it comes to herpes simplex keratitis, steroids are not technically recommended for this condition because, like other herpes simplex infections, it's usually self-limited. So it's thought that steroids can only sort of increase the harm, not really help. And often these, again, get referred to an ophthalmologist. Now, if we switch over to another member of the herpes family, which is zoster, then we have some other features to discuss. So when we get zoster in the eye, this is of the trigeminal nerve distribution. And remember that not only the eye gets infected, but typically the skin in that area as well. And often the skin can come first before the eye is involved. So when you see that little zoster vesicle on the tip of the nose, that's called Hutchison's sign, telling you that this is zoster and the eye is probably coming. It's probably going to follow that the eye is going to get the zoster keratitis. So you're going to look again for lid lesions. These are often common. They may have associated iritis, as many sort of deep keratitises do, and they may need steroids for that if it's really kind of gotten to that iritis level. They also get antivirals, just like the herpes simplex. They get pain meds, and they also get referred to an ophthalmologist. Now here's herpes simplex. You see those kind of little herpes simplex vesicles around the eye. This is more typical for simplex versus zoster, which looks a little bit different than this. You see that dendritic eye ulcer, that picture of the fluorescein stain where it looks that kind of classic tree-like pattern. And then here's somebody who's got zoster in that V1 distribution, those crusted vesicles. The eye is obviously, looks like it's getting involved here. If it's not already there, you definitely would want to refer because it's probably coming. And you see that the lesions go all the way to the tip of the nose. Here's somebody who's got vesicle lesions, vesicular lesions on the tip of the nose that are crusting. The eye doesn't look too involved yet, but again, you would refer that person. It's probably coming if it's not already there in some subtle fashion. All right, this one I want you to put a big star by, circle. This one you got to know. This will be on the test because it really is one of those ophthalmologic emergencies that's vision threatening that we have to recognize. This is the patient who has an acutely red, painful eye. They describe some blurred vision or halos around lights. Associated with this red, painful eye is often sort of almost like a migraine picture, some nausea, some headache. That can sometimes be a distractor. In the vignette, you're kind of going down thinking about red flag headache type stuff when you should be thinking about acute angle closure glaucoma, one of the other real important causes of headache to consider. On exam, classically, it's described as a hazy cornea. They've got a red injected eye, often a fixed mid-range pupil because they've got an APD, an afferent pupillary defect. Narrow angle closure glaucoma happens when you have a narrow angle and the aqueous humor that's inside of the eye is no longer able to sort of flow out as it normally does. And this happens in an acute fashion so that intraocular pressure shoots up and becomes vision threatening because again, behind that orbital septum, we have like a compartment of the eye. And if the intraocular pressure goes up, especially quickly, we can reduce the blood flow to that retina and give us visual acuity problems. So here's what that eye should look like when you really classically describe it. That hazy cornea, the pupil is dilated, kind of mid-dilated pupil. It's a red eye. It's injected around the outside. That could be a great visual stimuli asking you about what kind of medications you want to give this person, et cetera. So here's a good visual stimuli for acute angle closure glaucoma. The key test here is the intraocular pressure. If you had to know one number, that would be what you'd want to know. You'd want to know what the intraocular pressure was, and it's going to be sky high at ABEM General for sure, telling you that this is what the diagnosis is. In terms of a precipitating cause, the vignette could describe somebody who, just went into a dim restaurant, just came out of a dim restaurant. As people's pupils are dilating, this is kind of when it happens. Someone who also had their eye dilated at an ophthalmologist could also have this happen to them. There are risk factors. You can be hypertensive, have vascular disease. This kind of runs in families. Diabetes can also put you at risk for this as well. What do we do for acute angle closure glaucoma? Our goal is to decrease that intraocular pressure, and the way that we can do it in the emergency department is with medications. And so we've got a little bank of medications that we can use. One are topical beta blockers, right? Timolol. We all know that that's one of the glaucoma meds, and what it does is it decreases aqueous humor production. That's what it does. We also have alpha agonists, things like aproclonidine. This can also decrease aqueous humor production. And then we've got our carbonic anhydrase inhibitor, acetazolamide or Diamox, that we can give. Typically, IV is the way it's recommended for acute angle closure glaucoma. So these are kind of our menu of options. In addition, you could even go as far as to give an osmotic agent like mannitol. And the dose would be 1 gram per kilo, and you give that IV, and the hope is that it kind of sucks out some of that pressure and decreases again the aqueous humor that's in that intraocular compartment. Now, pilocarpine is also on the list. Pilocarpine is a topical miotic. It's one of those, it's very unusual. It shrinks the pupil, and it helps facilitate drainage of that aqueous humor. And it's recommended that you that's sort of further down the list on the things you give, because usually when the intraocular pressure is really, really high, you get this pressure-induced sort of paralysis of the muscle. So the pilocarpine isn't really going to work for you until you start lowering that pressure. So you really want to use it after that intraocular pressure is kind of starting to come down at least. So you want to call your ophthalmologist emergently. This is definitely vision threatening. And if your agents aren't working to bring down that intraocular pressure, there is something that the ophthalmologist can do that you can't do. They can actually do a paracentesis and to pull out some of that fluid, which is something that we don't do. But so that is something that they can do if these medications are going to fail. So we really want to bring down that intraocular pressure. We want to use our timolol, our aproclonidine, our acetazolamide. We've got our mannitol, pilocarpine's on the list, all of these things to decrease the intraocular pressure. That's a really important one to know. It's definitely an emergency. We have to know what to do for our patients, and the goal is to get that intraocular pressure down. Now let's kind of switch gears and talk about patients who present with a complaint of vision loss and what the differential is here and how we're going to tell the difference and what we need to do for them. So there's really only a few true visual field deficits that we need to know about for the exam. One is obviously if we've lost vision completely in one eye and the other one is normal, that means we've got a problem with that particular eye, whether it's the optic nerve, it's the retina, something going on in one eye, versus the other two, which is something going on with the brain. So the other one is the bitemporal hemianopia. When you lose the temporal visual fields in both of your eyes, but the inner part is okay, that means you've got something sitting in that pituitary spot, right there in that optic chiasm. You've got a pituitary tumor sitting there, cutting out your temporal visual fields in both of your eyes, bitemporal hemianopia. The other one is when you've had a stroke that affects your optic tract, when you've had a CVA, and basically you cut off, we call it homonymous hemianopia, you cut off the corresponding visual fields in both eyes. So you see in number 3 here that in both of the eyes we've got sort of the same visual field cut off. And this is the most common thing you see in stroke. And this is when you see a patient's eyes and they've drifted off to one side. The eyes will drift off to the side where the vision is preserved, basically. Now that they've lost this part of their visual field, the eye will drift over to the area where the vision is preserved. And they look to the side where the lesion actually is, because remember that you have that kind of crossed over pattern. So the eyes will drift to the side on where the stroke is, and that's where the visual field is actually preserved. So monocular vision loss means there's something with one side, the globe, the retina, the optic nerve. It could be temporal arteritis, for example. When you've got bitemporal hemianopsia, you've got something sitting right there at the optic chiasm, a pituitary tumor, maybe an aneurysm, something sitting right in that spot. And then when you're talking about homonymous, same side of the visual field, homonymous hemianopsia, that is optic tract problem, and that's a stroke. And the eyes go to where the visual field's okay, and that's the side where the stroke is. Now, one of the other causes of visual loss in one eye is CRAO. We'll talk about CRAO, arterial occlusion, versus venous occlusion. CRAO is a sudden, painless, monocular vision loss. No pain, all of a sudden I can't see out of one of my eyes right away. Now, this may have come and gone, in which case we call it amaurosis fugax, which you got to think, when you think amaurosis fugax, think TIA of the eye. That is what it is. Basically, you've had a little clot come and block off the vision, and then all of a sudden it goes away. That is a TIA of the eye. The ophthalmic artery, the retinal artery, is a branch of the CNS. It is just like having basically a stroke of your eye, which is what a CRAO really is. Because you've got ischemia to that retina, you will get an APD, and you will have a pale, non-perfused retina because it is an arterial occlusion, and you will have that fixed dilated pupil. Now, you do see in the macula, the very special part of the retina, you will see a little bit of blood flow there, which is called the cherry red spot. And the reason is because it has a little bit of a different blood supply. It's got a little extra vessel that goes there, preserving some perfusion to that area. So on your fundoscopic exam, you see this big, pale, non-perfused retina with this tiny little cherry red spot because it has its own special secret blood supply. You can see this boxcar look to the artery because there's something slugging up the flow, there's a clot, there's something there. These are mostly embolic, so in addition to calling an ophthalmologist because you've lost vision in an eye, you have to also think of the neuro workup that they need. They also need a neuro workup just like they would if they had a TIA or a stroke because there's something, this came from somewhere. There's some etiology that you have to be looking for in terms of the CRAO. Now, what can we do for a person who's got a CRAO? They've got no blood going to their back of their eyes or anything that we can do. Well, the thought is if we were to lower the intraocular pressure in there, not that it's elevated in this particular condition, but if we could lower it a little bit, we could promote extra blood flow. Maybe the blood flow will start up again. So we do a lot of the things that we do for acute angle closure glaucoma, trying to lower that intraocular pressure. We also can try to gently massage the globe, thinking that maybe mechanically the little clot will sort of move along the way. We could dislodge that emboli. That's why the gentle massage is on the list of things we can try. We can also try to have that patient rebreathe into a brown paper bag with the thought that we might increase the PCO2 and that could dilate the retinal artery and promote blood flow. I think these are all kind of Hail Marys, but they're on the list of things to try. I mean, vision is at risk here, so we're going to try it. And then you can consider the things that we use for acute angle closure glaucoma to decrease that intraocular pressure. The carbonic anhydrase inhibitor, the timolol, all of those kinds of things you could consider as well. And then again, the ophthalmologist could do an anterior chamber paracentesis and pull some of that fluid off to again try to restore blood flow to the back of the eye. There's only a 90-minute time window to restore vision if you have a true central retinal arterial occlusion. We know a lot about arterial occlusions in other parts of the body, and so think about it of the eye. It's going to be a short window. There's some things I can try, but it's a pretty desperate situation. And again, think about it as a stroke of the eye. Now here's your fundoscopy skills at ABEM General are phenomenal. Everybody has a panoptic there. You will see retinas like you've never seen before at ABEM General, and this will be one of them. So here you have this pale retina, not very perfused, with this little cherry red spot because it's got its own secret little blood supply to the macula. So it just looks like there's not much going on in the back of that eye because there's no arterial perfusion. This is another picture, again, just not much going on, just a little bit of blood flow in one spot. This is an arterial occlusion to the back of the eye. Now, if you think about central retinal vein occlusion and almost think about it like you know stuff about DVTs, if you occlude the vein, what's going to happen? You're going to get a backup of blood flow. You're going to get swelling. You're going to get discoloration. This is what happens in a CRVO as well. If we occlude our central retinal vein, it's going to result in edema and hemorrhage from sort of the pressure of the backflow if we've occluded our vein. Now, the story of vision loss for this patient is going to be a little different. It's more gradual. They've got a more gradual onset of vision loss versus the CRAO patient has a quick, sudden onset of visual loss. Their artery is occluded. Now we've got the other scenario. The vein is occluded. So it's a more gradual onset of vision loss. And when you look in the back of that eye, it's going to look a lot different. You're going to see retinal hemorrhages. You're going to see macular edema. It's going to look quite different. Now, what do we do for a CRVO? Well, there's not a lot that you can do, but the good news is the prognosis is better than with a CRAO. So the venous side, it has a better prognosis. We're going to send them to an ophthalmologist. They may get something like aspirin, but there's nothing really acutely that we can do to sort of resolve this issue. But you will see the blood and thunder retina, that backup, the edema, and the hemorrhages in the back of the eye. And that's what this looks like. So this is the blood and thunder. These little micro hemorrhages, it looks like there's a lot going on because that vein is occluded and you've got the backup happening, causing these little hemorrhages all over the place. Okay, so that's CRVO versus CRAO. Another cause of visual loss that you may see is optic neuritis, as the optic nerve gets inflamed. This is a pretty kind of funny, non-specific story of vision loss, but they often have pain associated with it. So that differentiates it from CRAO and CRVO, because now we've added painful eye movements to the story of this patient presenting with vision loss. They often will have an APD because of this inflammation that they're having in their optic nerve, and they may have, almost on a fundoscopy, it looks like papilledema or papillitis associated with the swelling of the optic nerve. Loss of color vision is also associated with optic neuritis, and when we think about optic neuritis, we should think about multiple sclerosis as the etiology until proven otherwise. So here's a picture of a fundoscopy in optic neuritis. It basically looks like papilledema in the back of that eye, and in the right story, maybe loss of color vision. There's some pain associated with eye movements. We might think about optic neuritis in that particular scenario. Again, loss of color vision being on the list there. Now, what about retinal detachment? This is one, again, I would circle. This is really common for us to see and to consider. What do we need to know about retinal detachment? Well, as we make a little tear in the retina and you get the vitreous humor sort of working its way in there and it starts to tear the retina a little bit more, this is obviously very vision threatening. There are risk factors for retinal detachment, and often people have had some kind of history of eye problems before, but not always. They certainly cannot, they don't always have that. In terms of symptoms, this is painless. This is a painless vision loss. And the kind of key words to think about in the story would be someone who's seeing flashes of light, flashes and floaters, lowering of a curtain in the visual field. That is retinal detachment. Maybe some decreased peripheral vision. So floaters, spider webs, flashes, lowering of a curtain. Think about retinal detachment. Picture that vitreous humor kind of working its way in and tearing that retina away and causing these various visual symptoms that they describe. So as you tear that away, you start getting all these visual symptoms. And we, on fundoscopy, you've seen the pictures where it sort of shows this gray retina with these folds as the aqueous humor is working its way in. We can't see all the edges of the retina. We certainly know this. And so it is a diagnosis that we have to suspect clinically, but need to refer to an ophthalmologist, of course, for a more complete exam. Ultrasound has been a big invention for us in terms of being able to see in the back of the eye. And ultrasound can be quite helpful in this diagnosis. On the exam, you will not be asked to interpret ocular orbital ultrasound images. It will not be on the exam. That is not something that is testable. But just to know that ultrasound has really helped us kind of get this diagnosis a little more confidently. Especially if the vision is still intact, there is still some vision intact, that really is an emergent ophtho referral for sure. If they've lost their vision completely, it's a macula off type of retinal detachment, not quite as emergent for the ophthalmologist. Often there's not much they can do to save that vision. So if there is MAC on, they have some vision left, definitely possibly reversible, time sensitive, versus MAC off, not quite as emergent if they've already lost their vision. Another vision threatening thing that is an emergency is giant cell arteritis, temporal arteritis of the eye. So this is in your older patients, often presenting with a unilateral headache. The headache's been gradually getting worse. It's often classically described as worse at night, unilaterally over the temple. And up to half of them, when they present, will have some degree of impaired vision. But this is a vision-threatening emergency. It can present almost like an amaurosis fugax, where they've got some, they and then it returns. But the thing is that if it's left to progress, most of them will go on to blindness, at least in one eye, if not both eyes, if they're not treated emergently with high-dose steroids. So it's really a clinical diagnosis, because after the first eye is affected, it'll progress to the second eye. Now, the American College of Rheumatology has put out of course, some diagnostic criteria. These don't need to be memorized, but they give you a picture of what that patient would look like. Age over 50, a new onset headache, typically unilateral. They may have temporal artery tenderness or a decreased pulse there. Their SED rate will be quite elevated, and then ultimately, right, the clincher is the biopsy showing the arteritis in that temporal artery. Because it's not just located, this giant cell arteritis process is not just located to the temporal artery, it also goes to the other arteries in the face. They may also describe painful chewing. When they chew things, they're having sort of pain in that area. That could be a clue in the history. Pain with mastication, that could tip you off to, this could be a giant cell arteritis case. So it may be described as warm, some tenderness over the temple. They can have an afferent pupillary defect because, again, from the arteritis, they may be getting ischemia to the back of that eye. And the optic disc, because if you're getting arterial ischemia, it would look just like a CRAO. It would look pale and edematous. We want to call ophthalmology, but we have to clinically suspect this, and the answer of what we can do is to start high-dose steroids empirically based on the right clinical picture. And so certainly if those symptoms have been going on for less than 48 hours, we want to go with IV methylprednisolone to try to decrease the inflammation and save their vision. So that is the emergent treatment that we need to know about. Now let's move on to trauma of the eye and talk about some of the things to know here. Chemical exposures, this is pretty straightforward. So we've got alkali and we've got acid. If I had to put something in your eye, which one would you want in your eye? If you had to choose alkali or acid, you would choose acid, right? Alkali is the worst. Of the two, alkali is the worst. Alkali is worse than acid. Alkali causes a liquefaction necrosis. Sounds awful. Tends to penetrate quite deep. Acid, not good either, but not as bad as alkali. Coagulation necrosis, not as deep as the alkali injuries. Any kind of chemical exposure to the eye, the thing that we can do is irrigate. Irrigate, 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 irrigate. Trying to wash it out of the eye, going to try to shoot for that normal pH. You need that pH paper to check what the pH is of your eye. So you irrigate that eye until the pH gets back to normal. That is what we can do emergently for chemical injuries to the eye. These are really bad burns. They cause anything from ulcers to just complete burns of the eye, pretty devastating injuries if left to be exposed. Okay, hyphema. We've got some red blood cells in the anterior chamber of the eye. This can happen from trauma. It can also happen spontaneously in patients who are, for example, on anticoagulants. The thing about a hyphema after you get these red cells in the anterior chamber of the eye is that just like, you remember the story where the kid chews on the electric cord and they get the anterior labial artery bleed? Why is that a big deal? Because, a week or two later as the clot retracts, they can get a rebleed. This is like that. This is what hyphema is. Basically, you get these red cells in the anterior chamber of the eye. As the clot starts to form and retract, you can get a rebleeding that might be even worse than the first bleed. So that's why hyphemas, we're concerned about that rebleeding period, and we want patients to just really take it easy with the head of the bed up and the whole 9 yards. They can also be at increased glaucoma risk from these red cells in the anterior chamber. They can get staining and decreased vision from all this, but the most common complication is that rebleed as the clot retracts and they basically bleed again. Red cells layering out in the anterior chamber, that is hyphema. And this can be anything from a little bit to the whole anterior chamber of the eye, in which case we call that an 8-ball hyphema, right? When it's all the way up and they have red cells in the entire anterior chamber. So here's that little layering of red cells, there's your hyphema, and this one you see, there might be some signs of open globe there too, which we'll talk about in a minute. So the treatment is bed rest, elevate the head of the bed. We often protect these with an eye shield. It's going to get an ophtho consult. If they have increased intraocular pressure, then we have to treat them the same as glaucoma and go after decreasing the production of the aqueous humor and the whole 9 yards there. No aspirin, no anticoagulants. And some of these, if it's a pretty low-grade bleed and a reliable patient, could be treated outpatient. They don't all get admitted. But if they have an 8-ball hyphema, sort of occluding their visual access, that's going to come in and be admitted. There's an 8-ball hyphema, sort of occluding the visual access. Now here's another one to put a big star by. This is something we have to know about. We've got to be able to recognize a globe rupture. And there's a lot of different signs of globe rupture, and we need to know what to do for a patient who might have an open globe. So if we've got basically a corneal thickness, we've got a violation of our cornea, well, now that inner protected area of the eye, protected by that orbital septum, is now communicated with the rest of the world. It's not only vision threatening for lots of reasons, the infection, the whole mechanics of it, it's a big deal. It can happen from blunt force, it can happen from penetrating injuries, and there are a bunch of signs that we have to know about, and they're listed here. The teardrop-shaped pupil, the flat anterior chamber because the fluid's been spilling out, the black pigment, the uveal prolapse where the wound has happened, and the Seidel sign where you put in the fluorescein and the aqueous humor is leaking out and kind of washing it away and causing that river of aqueous humor. That's Seidel's sign. All of these things we have to be able to recognize. What do we do if we think we have an open globe or a globe rupture? Well, we just stop right there. We don't put any more pressure on that eye. We put on this is one of the times for the hard metal shield to really protect it. We don't do tonometry, although one of the classic signs of an open globe, since the aqueous humor is leaking out, is low intraocular pressure. That's one of the signs. But we're not going to go putting our tonopen on that eye, no tonometry. They get IV antibiotics. They get analgesia, antiemetics. We don't want any increased intraocular pressure from that. They get their life-saving tetanus update. They get a CT of the orbit to further define where the open globe may be happening from, and they get emergent ophtho consult, one of those real ophtho emergencies. So here's a picture of an open globe with a corneal laceration. You see that sort of teardrop-shaped pupil that we're supposed to know about right there on the edge, at the wound's edge, just classically described. There's your teardrop-shaped pupil. Here's another one of the teardrop pupil that you could see. Again, these could be good visual stimuli, ask you about what you would do for this person. Here you see not only the teardrop pupil, again pointing to where the wound is, but also the prolapsed iris that's coming out as well, that pigment coming out. Corneal abrasions we see a lot. I don't want to spend a lot of time on these because this is just bread and butter for us. The patient that comes in with the foreign body sensation, the tearing, we're going to evert those lids if we don't see anything to look for a foreign body. If there is a foreign body under there, it may have caused an ice rink sign as it's been going around and scratching up the cornea. And in patients with contact lenses, don't forget about the pseudomonas. That is a big deal. And in particular, in this case, they can't wear their contact lenses anymore, and they're going to get referred to an ophthalmologist for sure. And they're going to need aggressive antibiotic therapy of that. So here's that ice rink sign, the fluorescein stain of that foreign body that wasn't picked up on, that's been going around and around. And the answer here, I want to avert the lids. I want to look for that foreign body. I want to try to get it out of there. There's something causing that under the lid. Corneal abrasions, we give analgesics. We tell them not to wear their contact lenses. We update their tetanus. They usually get better. They should have some follow-up if they're not resolving. And they can get recurrent corneal erosions if it's not healing well. So that's why they need some follow-up with these types of abrasions. What if there's a foreign body in there? What about within our scope of practice to remove those? Absolutely. For the superficial ones, we can definitely do. Remember, though, we want to think about penetrating globe injuries when there's a foreign body in the eye, especially if the vignette were to tell you that this was a welder with some kind of metal-on-metal injury. They weren't wearing their protective eye shield. We want to think about a penetrating globe injury when you have that kind of high-force mechanism type of thing. Metallic foreign bodies, remember, they get a rust ring that can be removed in the ED and ourselves, or we can refer that to an ophthalmologist as well in the delayed fashion. Let's talk a little about blowout fractures. So the blunt trauma to the eye, we've got these orbital walls. Remember that there's a couple really thin areas of the orbital ring that we have to worry about. One is that medial wall of the orbit, very thin. That's where we get the lamina propria fractures. And if you fracture that, you actually could get some epistaxis from that fracture, even in the absence of nose trauma. So to think about that as a clinical sign of a lam-pap fracture. When we get that blunt force trauma to the eye, the other place that it goes is the inferior orbital wall. That is where it's also quite thin, and the orbital contents can herniate through that and cause entrapment there as well. If that happens, the muscle that gets entrapped that we worry about is the inferior rectus muscle. And the inferior rectus muscle helps us do upward gaze. So on exam, the patient can't look up in the setting of blunt trauma, makes you worry about an orbital blowout or an inferior orbital wall fracture trapping that inferior rectus muscle. They also can have infraorbital nerve involvement, giving them numbness of the cheek and the upper lip. That's the nerve that we often use to our advantage to do local anesthesia, to do repairs and things. They can also get nerve involvement from the mechanism, from the inferior orbital wall there. How do we image these? These days we're mostly doing CT scan. It's much more detailed, much more sensitive. You can do a plain film. It's what we used to do before we were doing lots of CT scans. And you'd see that maxillary opacity on your Waters view with the teardrop soft tissue mass. That would be an orbital blowout fracture. These days CT is preferred, and we want to think about open globe. We give them precautions not to blow their nose or Valsalva, and this gets referred for outpatient repair. Here's a picture of an old x-ray where you see the teardrop sign, the orbital contents kind of herniating through that inferior orbital wall, and air fluid level in that sinus, telling you that you've got the blunt trauma on that side. More commonly, it's a CT image these days where, again, you see that those orbital contents herniating through and there's some entrapment involved there. And again, on exam, this patient would have upward gaze problems when you looked at them clinically. There's that orbital floor fracture there as well. So here's a patient with an orbital blowout fracture. The one eye, the good eye, is looking up. The affected eye can't. This eye is also red, probably has some traumatic iritis associated with it as well. And that would make sense with their blunt force injury. So you worry about an inferior orbital wall fracture trapped of that inferior rectus muscle, can't look upward. That's the blowout fracture. Now, the other real emergency that can happen with blunt trauma to the eye is the retrobulbar hemorrhage. And now we're talking again about that safe space behind that orbital septum, that orbital compartment of the eye, where basically you get bleeding, causing a real problem there. So now we've got bleeding in the back of the eye. It's raising our intraocular pressure, causing ischemia to our retina, threatening our vision, means an emergency. So that patient, if they're awake enough to tell you that they have decreased visual acuity, that will be part of the story. Often they can have proptosis because of the bleeding that's happening in that closed compartment of the eye. They may have a dilated, non-reactive pupil. And what can we do for that? Well, we talk about medication to decrease the intraocular pressure like we would do with glaucoma, but this is blood, right, that we're talking about. So really what they need is a mechanical decompression of that blood, which is where the lateral canthotomy and cantholysis comes into play to basically release that pressure and restore blood flow to the back of the eye. So here's a patient looking from the above. We see that proptosis happening in the affected eye. Often the CT scan will also show us how much blood and where it is. But again, this is a patient where you'd want to get your tonopen, get an intraocular pressure. It's going to be elevated, and we're going to need to release the pressure on this eye from the retrobulbar hemorrhage that's happened in that safe, protected space back there. Now, in terms of trauma to the eye, remember that there are some lid lacerations that are out of our scope of practice. This is also something that ABEM wants to know, that we know kind of where the line is for what we should be doing, what we shouldn't be doing. We don't want to repair lacerations that involve the very margin of the lid. Certainly the tear duct system, the canalicular system, is an area where it has to be just right, or else they'll have problems with tearing and drainage of the tears. So that's a place we stay away from. Levator and canthal tendons, the orbital septum that we've talked about, we don't want to go there. That's when you will see some orbital fat coming out. That means that it's gone deeper than just the sub-Q tissues of the lids. And if there's any kind of significant tissue loss, out of our scope of practice. So remember that little canalicular system, if it's near these tear ducts, this needs to be referred to an ophthalmologist for repair. And often they might even put a little stent in there to make sure that tear duct system is left intact. I mean, I'm not going to try to repair this. I don't think you would either. This is certainly out of our scope of practice. And they could show you a picture of a lid lac and ask you, what you would do with this. And remember that these ones we want to refer. All right, the painful part, the neuro-ophthalmology, remembering what cranial nerve innervates what and does what in the eye, and when you have a patient presenting with proptosis, how we're going to sort through what their diagnosis is. So remember, this is kind of going all the way back to med school, and when you take your USMLEs, remembering that the third nerve of the eye does pretty much everything in the eye. It's kind of like the main player in terms of eye movements. It controls all of these upper movement, lower movement, and there's two other nerves that do different things, the fourth nerve and the sixth nerve. The fourth nerve helps move our eye down when we're looking towards our nose, and our sixth nerve helps us abduct our eye and look out laterally. And pretty much everything else the third nerve does. So one of the mnemonics that you learn when you take your USMLEs is the SO4, LR6, everything else is the third nerve. That the superior oblique muscle, that's the fourth nerve, lateral rectus, that's the sixth nerve, everything else is third nerve. And these are basically, impaired extraocular movements and how you're sorting through what's happening with them. Probably the most common one is the lateral rectus one to know about. And we'll talk about how these pertain in a little bit. How about how we open and close our eye? This pertains to the ptosis discussion. So from patients with Bell's palsy that it's the seventh nerve that closes the lid, right? We close our lid with our seventh nerve, which is why they can't do it with any strength. So a facial nerve palsy, we have an impaired eyelid closure. You can think of the seven as a little hook that closes the eye. What helps open our eye? There's really two things that do it. The third nerve, of course, because it does everything, but not only the third nerve does it, the sympathetic nerve system also helps us open our eye, right? Because as we're running from the tiger, our fight or flight syndrome, we're going to open our eye, we're going to let the light in, and we're going to start sweating from the tiger that's chasing us. So not only the third nerve helps us open our eyelid, but the sympathetic nerve also helps us open our eyelids. We have this sort of double innervation, which leads to how we talk about ptosis and which one is which. So there's two different things that help us open our eyes. So whether it's the sympathetic chain, which is Horner syndrome, or a third nerve problem, both of those things can result in ptosis. But they result in a different, sort of complex of symptoms, which we'll review. What about our pupils? Well, we basically have sympathetic and parasympathetic output to control our pupil, right? The sympathetic nerve, our fight or flight, makes our eye get bigger, right? The third nerve helps dilate our eye. What helps make our eye small? Well, it's the parasympathetic nerve, the opposite. And it turns out that the parasympathetic nerve runs right along with the third nerve. They're best friends. They love to be together. And so when we have a problem with the shrinkage of our eye, the parasympathetic side of things, it also is really tied in with the third nerve as well. So the parasympathetic innervation, what makes our eye small, runs right along with the third nerve. And when things affect the third nerve, it can affect this dilation of the eye, right? So if we have a third nerve problem, if we had a problem with our parasympathetics, if I took out your parasympathetics, what happens to your pupil? It gets big, right? Because you have unopposed sympathetics. The parasympathetics make it small, the sympathetics make it big. So when we have that unilateral dilated pupil, that anisocoria, what do we worry about? We worry about the fact that we have basically unopposed sympathetics. The parasympathetic side isn't working. It's not able to make our eyes smaller. And it runs right alongside with our third nerve. And remember that aneurysms can push right on that area and cause that unopposed sympathetic, basically taking out the parasympathetic from pressure, mechanical pressure. When we are testing our light reflex, we are testing the ability for our eye, the retina, the back of the eye, to see light, to perceive light. We're also testing our pupil's ability to get big and get small. So it said here in red, compression of the third nerve caused an ipsilateral fixed dilated pupil, because if I compress the third nerve, I'm also taking out the parasympathetics, meaning I have unopposed sympathetics, making my eye dilate. Now this is where it comes into an APD. What is an APD? When you do the swinging flashlight test, what are we testing for? What is that telling me? And I'm going to really make it as simple as this is how I think about it. If I'm shining a flashlight into your eye, right, I'm testing your retina. If your retina is working, it doesn't have ischemia to it, it doesn't have any problems, and it perceives the light, it tells both of my pupils to get small, right? So if I perceive light well, then my pupils get small. If there's something wrong with my retina, I have ischemia to it. It's swollen from optic neuritis. There's some optic nerve problem that I'm not seeing light appropriately, I'm not detecting light appropriately, and it's not sending the right signal to my eyes to tell them to constrict. So the way that this works when you do the swinging flashlight test is if I got equal pupils and I shine the light in the good eye, my optic nerve is working, the retina is working, it tells my pupils to constrict, right? Now I move the flashlight to the other eye where I've got a problem. I've got optic neuritis, I've got a CRAO, I've got ischemia, something wrong with my retina. So my afferent, my information where the light is coming in, telling my brain the light is coming in, is broken. There's something wrong there. So what happens to my pupils, right? They're not going to stay constricted because the signal's not going through. So what happens is they dilate. What they really are doing is going back to normal because the signal's not getting through, telling them to keep small. So they go back to normal. So it looks like they dilate. And that's just because the signal is broken, because there's something wrong with my retina, and so my eyes dilate. They really are just going back to normal. They're not getting huge, they're just going back to normal. And that's really kind of what is going on there. So that's really what an APD or a swinging flashlight test is all about, is basically, is your optic nerve, is your retina working? Is the signal that there's light coming in getting through, and is your pupils responding in the way that they're supposed to? It's really a test of that back of the eye. And so if you go back through and you look at all the conditions where it says you get an APD, they're all the things where there's something wrong with the retina, there's something wrong with the optic nerve. That afferent level is impaired, and so you get an afferent pupillary defect. Makes sense, that's an APD. So these are different pictures just illustrating the problem of an APD and what you get clinically. So just reviewing these pupillary syndromes. So we've got our sympathetic chain, our fight or flight. It tells me to run from the tiger. I lift my eyelid, my pupil dilates, I get sweaty on that one side. So if I take out that sympathetic chain, all of those things go away. Now I have ptosis because I can't raise my eye all the way. I'm going to get a constricted pupil because that fight or flight big pupil went away. So now I've got miosis, and I've got the anhidrosis, the lack of sweating. That's Horner syndrome. And remember that the sympathetic chain comes out of the thorax, travels up through the neck with the internal carotid. So it could be a tumor, it could be a laceration, it could be a dissection, it could be different things that affect it that can give you Horner syndrome and take out that sympathetic chain causing that spectrum of symptoms. So here's Horner syndrome. You've got the ptosis, you're going to have a small pupil because you now have unopposed parasympathetics making it small, and you're going to have the lack of sweating. They'd have to tell you about that. So that's what Horner syndrome looks like. That's going to be different than a third nerve palsy. If I take out my third nerve, I also will get ptosis because my third nerve helps me open my lid, but now, remember what runs along with the third nerve, it's best friends with the parasympathetics. So if I take out the parasympathetics, now I get a dilated pupil, very different than the sympathetic chain problem, different than Horner's. You have a dilated pupil instead of a small pupil. And if I also take out the third nerve entirely, I'm taking out all of that stuff it does with the eye movements, and so that lateral rectus, the sixth nerve that's still intact, pulls it out to the side. So you get basically this sort of deviated eye. That's a third nerve palsy. And this is another slide just illustrating those two things. If I only take out my sixth nerve and I can't look out to the side, then that's going to be an isolated lateral rectus problem, pretty easy to pick up on. So this is like the money slide. This summarizes all of what I just said. It gives me the ptosis, whether my pupil is big, whether it's small, the anhidrosis, if my eye is deviated or not, and it goes through Horner's. If I take out my sympathetic chain, I've got ptosis, I've got a little pupil because I've got the unopposed parasympathetics, so I wiped out my sympathetics, and I've got the anhidrosis. If I take out my third nerve, I also have ptosis, but I have a big pupil, right? Because now I've taken out my parasympathetics. That runs with the third nerve, and I get lateral eye deviation. And the sixth nerve is just basically, I can't deviate my eye out laterally, so it's stuck in the middle. So those are the ocular dysfunction syndromes, a very quick review of those things. Thank you very much, and I'm going to welcome Dr. Matudak back to the stage here. Thank you.